Oh, Hi, welcome to this webinar sponsored by Elder Voice Family Advocates. I am Chris Sundberg, Executive Director of Elder Voice Family Advocates, and Jean Peters is our president, and Nancy Haugen, our RN member and volunteer expert on elder care issues. We are bringing these informational programs so viewers can learn more about the issues that have significant impact on residents, families, and staff of long-term care. Today, we have the leaders of the Office of Ombudsman for Long-Term Care. They are here to talk about their work to help residents and their families who are having a wide variety of issues with care or other problems. Additionally, they're going to discuss the current situation in long-term care. Their work is incredibly important, and we appreciate them so much so that we have testified in support of increasing their funding so they could hire more staff. At the time, Minnesota's funding for the ombudsman was one of the lowest in the nation. It is with great pleasure to have Director Cheryl Hannon and Deputy Directors Aisha Elmquist and Genevieve Gabori. With that, I will turn it over to Cheryl, and thank you and welcome.
Hello, everyone. I am Cheryl Hennon, the State Long-Term Care Ombudsman. Thank you, Chris Sundberg, Nancy, and Jean, and all members of Elder Voice. I want to thank you for this opportunity today to talk about the Office of Ombudsman for Long-Term Care and the effects of COVID-19 on people living in long-term care communities. Federal and state law mandate ombudsman for long-term care programs in every state. Residents have a right to access ombudsman services free of reprisal. We are especially trained and designated to provide advocacy services. Ombudsmen have the facts and know federal and state resident rights and regulations. Aspects of living in long-term care settings have changed since the COVID-19 crisis began. What has not changed is the right to expect quality, individualized care. Facilities are still required to provide the care and services your loved one needs to reach his or her highest level of well-being. I express my sincere sympathy to those who have lost during this pandemic. Nationwide, deaths in long-term care facilities account for, at least, and this percentage may have changed today, 40% of all COVID-19 deaths. In 18 states, Minnesota being one of them, COVID-19 deaths in long-term care facilities account for at least half of all deaths. The disproportionate number of COVID-19 deaths in long-term care settings serves as a reminder that residents and staff in these places continue to bear a high burden of the uncontrolled pandemic. One of the biggest challenges for people living in long-term care settings has been the restrictions on visitation and resident separation from families and loved ones. This has been exceptionally difficult for residents and their families. Many people are worried about their loved ones' health and safety, rightly so, during this crisis. When will they be able to get back together, and what will that reunion be like? The Office of Ombudsman for Long-Term Care, we continue to advocate for people in long-term care communities and encourage people to reach out to our office. I want to sincerely thank all of you for the support, as Chris mentioned, that you have given to the Office of Ombudsman for Long-Term Care, especially in increasing our staff. The more of us out there, the more residents have access to our very important services. I will now turn this over to my staff member. Next slide, please.
I'm Genevieve Gaborio, one of 2 deputy ombudsmen in the office. Thank you to Elder Voice Family Advocates for the opportunity to share more about our work. I'll be giving an overview on a few slides about how the office works, how people can reach us, and then I'll be turning it over to Isha Elmquist, who will talk some more about the policy related to COVID. So first, we truly are person-centered client advocacy. We represent and help support what the resident at a nursing home or assisted living or other site wants to achieve. So we serve all adults receiving licensed long-term care services and supports in Minnesota. And as you can see, we really try to help everyone. We don't have income screening, no referral requirements, we're free. And calls are welcome from residents. And we of course have many calls from friends, from family, and a lot of calls come in from facility staff wanting to discuss or troubleshoot a particular issue. We serve residents on a geographic basis. So by that I mean that if you're living in a facility in Willmar, you'd be assigned to the regional ombudsman, which we call RO for short, who serves the Willmar area. And by having these geographic specific defined regions, it really helps to build trust and relationship with our ROs and the residents, and also with our ROs and the facility staff, which makes it more efficient and just a better partnership to work collaboratively to solve issues. To find your regional ombudsman, you just call our central intake line, the 651-431-2555 number. We also have a toll-free number for those who need it to request assistance. And our mission statement is here, and it's really to empower, educate, and advocate alongside Minnesotans who are receiving long-term care services and supports to ensure their rights are upheld. And so part of our work is not just to someone calls us and we go fix something, it's to talk to that person about what their rights are, what choices they have to address it, how they could perhaps file their own grievance if they'd like without us to be more involved, so that they're educated and empowered to tackle the next issue in the future. Next slide, please. Here is just an example of our map. This frequently shifts as we add new staff. We've had a wonderful building period since the 2019 legislative session, where we've grown from 14 regional ombudsmen to currently we have 24, with one more to be hired in the works. So this is our current regional setting. We have about 18 people serving around the state. Some of those who border the metro have some metro responsibilities. And then there's 6 more not pictured on the map that serve residents just in Hennepin and Ramsey counties, where the bed count and facilities are quite dense. But again, you would just call our main number to get assistance. You don't have to know which county you fall in. We'll get you to the right person. So on this slide, you can see ombudsman is just a Swedish word for advocate. Ombudsmen are not the same as adult protection or MARC. So we're advocates, again, for the residents and the residents' wishes. And so sometimes residents don't necessarily want the same thing that somebody else would think is best for them. And so it is the RO's role to talk to that resident about their wishes, about options. If, for example, they don't want to live in the facility anymore and want to go back home, talking about, well, if you just leave, there could be that could cause problems. Why don't we get you assessed to see if we could get if you could be eligible for services at home, to see what other supports you could qualify for, perhaps to find a different setting for you. But just walking out and leaving could be unsafe, and that actually could trigger adult protection being involved, and making choices for you instead of helping you make the choice that's best for you with a lot of information and support. Part of how we can be so successful is that our work is confidential. And so when clients, residents talk to regional ombudsmen, what they tell them is private. They're not mandatory reporters. And so we often work with residents. If something abusive is occurring, we'll work with residents. Or if the family is the person who's called, we'll let the family know that they may want to file a report. They should file a report. But if we're working just one-on-one with a resident and the resident does not want us to do that, we really can't make a report, but we can find other ways to try to support the resident. And also, different from adult protection, we're not an emergency response. We answer calls during normal business hours, Monday to Friday, and try to respond within a few business days. We respond more quickly. If it's something of a more urgent nature, abuse, eviction, more of a crisis type situation, we will respond more quickly. But again, we're not an emergency service. So we're not the police, we're not adult protection, and we're not MARC. So if those are who you need, and you would call our office, we would refer you to those agencies to make those complaints yourself, or to try to get help to make those complaints. Next slide. So residents have an absolute right to use Ombudsman services. We are allowed and available to long-term care residents under federal law and state law. If someone interferes with our work, that's a problem, and we have the right to complain about that and get access to files, to whatever we need. It's illegal for anyone to retaliate when a resident does assert their rights to ask for help of an ombudsman. And the assisted living law that will be in place in 2021 and actually already strengthens residents against retaliation for making complaints. And if residents do fear retaliation or believe they're being retaliated against, they can make a report to the MARC and ask for advocacy services from the Ombudsman as well. Next slide. So as the whole world has had to adapt and change due to COVID, the Ombudsman's office has also been a part of that. We are mandated under federal law to have a regular presence at long-term care facilities. So before COVID, that meant that at any time we could go into a facility without needing to make an appointment, without needing to get that cleared or let the administrator or house manager or anybody else know that we're coming. We still have that authority, but out of respect for infection control and trying to not bring in COVID to facilities, we have not been exercising that right to just be in as a regular presence since March. In March, we did switch to a virtual presence. So we've been serving residents over the phone with video calls and trying to do the best we can in that format. As an attempt to try to maintain a regular presence, we have encouraged staff to make outreach calls to facilities. So if an RO hasn't had any cases from an assisted living in their region and wants to just see how things are going, we've got a list of questions that they can call and ask to support that conversation and find out if they need any assistance. Maybe that makes the social worker or whomever they call think, oh yes, why don't you talk to this resident? So that has helped maintain our connection and relationship with those facility staff. The office is moving on a phased approach to return to in-person visits. Being at the bedside of residents is really the heart of our work. It's a unique service that the Ombudsman provides to primarily work with people face-to-face instead of over the phone. So it was a very difficult decision to stop doing the in-person visits. But of course, COVID has been just a very difficult situation for all of us. So at this point, we're doing a phased approach to return to in-person visits. So in October, we began meeting with clients in person at window visits, as well as outdoor visits. And the staff were just very excited about being able to go out and have that direct client contact in person again. And it's been beneficial to the staff as well as to residents that they've been able to meet with. So starting next month, January 2021, the OLTC will begin meeting with residents inside facilities and will return to a regular presence. And so we're doing that with PPE provided to the staff, with a thoughtful policy about how to avoid spreading infection, and the staff will be starting that soon. Next slide. And here I'll turn it over to Aisha Elmquist to keep going through the slideshow.
Hello. Can you all see me and hear me? I cannot see myself. Okay, well, hopefully this is working okay. I am Aisha Elmquist, and I am, oh, there I am. Hello, everyone. I think there was just a little lag there. I am Aisha Elmquist, another Deputy Ombudsman with the Office of Ombudsman for Long-Term Care here in Minnesota, and really thrilled to be here with you today. As you can see, this first slide is talking about the top complaints to the Ombudsman's office that we have seen in recent months. Before I go into this slide, I want to talk a little bit about the Ombudsman's office work in the policy space. And I know some of you are familiar with that because we've done some work together. In addition to individual resident advocacy, we do systemic work as an office. This can include having input on legislation. A prime example of that was the wonderful work that happened with assisted living licensure, which we know is going into effect in August of this next year. And that was work that we did with Elder Voice and many other partners to come to an agreement about a new framework for assisted living in the state. That was critical work that we knew needed to be done based on years of casework in the office. So we were very thrilled to see that change and are continuing to look at how that law may need some tweaks here and there. We know there was just legislation passed in a special session to do some of those tweaks and get some of that done. That's an example of the type of work that we do. In addition, we look at systemic casework at the individual facility level and across facilities. So as an example, we may do individual casework at a particular nursing home, but we may also see some themes or trends about that work and approach management, others at the facility to say, hey, we've had 5 cases about this particular issue. Can we try to look at this in more of a systemic way instead of an individual case way? Or it's not either or, it's both, right? Another example may be we may see trends for a particular company across the state where we're seeing trends at multiple nursing homes or multiple assisted livings that are owned by the same company, and looking at that as well in a systemic way if there are some ways we can make difference there. One thing we're so excited about, in addition to increasing the regional ombudsman staff, which is really critical, We have 2 new policy staff who came on in recent months and are very excited about the work that they will do and increased capacity that our office will have to address some of those policy issues now that we have increased staff numbers in that area as well. So thank you, as others have said, to Elder Voice for their support of that increased staffing, and we're definitely seeing some very positive results coming from that. Thank goodness it came when it did, because of course we did not know that COVID-19 was coming. And if we had not had that increased staffing when we did, I don't know what we would have done. It was absolutely critical, given the increase in calls that we have seen coming into our office because of COVID-19. So with that, I will go here into some of the top complaints to the Ombudsman's office during the time period of COVID-19. So really looking at March forward. Some of the top complaints we've seen, visitation has absolutely been number 1. This is the case to COVID-19. This was change in complaint numbers that we have seen is this rising to the top. And I don't think anyone will be surprised that that rose to the top. One thing we have certainly seen with respect to visitation is that visitation is a rights issue. Visitation is a safety issue. And many of you who are listening to this call absolutely know family members, friends, loved ones, spiritual support. So many things come from visitors in long-term care that are essential to well-being, quality of life, safety, health. Isolation is harmful to people. And we have absolutely seen that through the complaints that we have received related to visitation. Also want to acknowledge the significant effects that COVID-19 has had in our long-term care facilities. It's absolutely tragic how many people have died in the past year due to COVID-19. And that's certainly something that comes up again and again in the calls that we receive, as well as that concern for the safety of loved ones, questions about what is the right decision to make for my loved one in this particular circumstance, and calls directly from residents as well related to COVID-19 and concerns that come up related to safety related to COVID-19. So there are so many different stressors that we are seeing in long-term care right now. And that explains a lot of the increased call volume that we have received. Another complaint that we have received very commonly is discharge, and a huge tool that we have been able to use in our work is the eviction moratorium that is currently in effect. The Attorney General's office has been a big resource for us, support from legal aid, as well as the work that we're doing directly to help to avoid discharge at this time, and also to ensure that people have the right to return to their facilities if they do leave. They may be subject to quarantine upon return, but really making sure that they are able to return to their homes. Third is deprivation of rights, such as personal liberty or freedom of choice, right of assembly, speech, religious freedom, the right to vote. A critical piece here, which I'll talk a little bit about in the next slide, is really that personal freedom element, and people wondering, what are my rights to see my family, to go into the community, to go to a medical appointment? These sorts of questions are coming into us. Fourth, staffing. And this is a complaint that was in existence before the pandemic and still is a significant concern, which is problems with shortage of staff, turnover, overuse of temporary agencies, etc. This also subsumes complaints about the skills or training of staff and similar complaints. And fifth, this is something that was in existence prior to the pandemic, and we still see is one of the top complaints being residents treated with rudeness, indifference, or insensitivity. Next slide, please. So looking at comparison to our top complaints prior to COVID-19, as I mentioned previously, a very substantial increase in complaints about visitation, significant amount of complaints about people in long-term care not being allowed visitors. And to provide a little bit of a description of what we've seen and how this has evolved over time, at first, only compassionate care visitors could visit in long-term care. And compassionate care visitation is something I want to take a moment to really focus on. From the beginning of the pandemic, CMS and DH, so this is applicable to nursing homes and assisted living, have both said not only that compassionate care visitation can occur, but that it must be allowed. And there are several examples of compassionate care that are outlined. They can include end of life, and that does not mean 2 hours before death. End of life is broader than that, and we certainly advocate for that. It can include end of life. It can include something that looks very similar to essential caregiver visitation. It can include someone who perhaps has had a physical decline due to the lack of a caregiver being in place, and really needs some additional support. If you want to see the specifics, I certainly could direct you to the CMS guidance so you can see a little bit more specifically what that looks like. But the important piece here is even if a facility has a COVID-19, someone who's diagnosed with COVID-19 in the facility, even if a facility is in a location that has high COVID-19 positivity rates, that compassionate care visitation is something that still should be occurring, and we've certainly done a lot of work in that area. So at first, that was really the only exception of when visitation could occur. Then we saw over the summer that MDH issued some window, outdoor, and essential caregiver visitation guidance. But these, unlike compassionate care, were up to facility discretion. And MDH's website is a great place where you can find information on the most current visitation guidance. Recent CMS guidance substantially expanded visitation in nursing homes, which MDH adopted for assisted living facilities. So in the summer, indoor visitation was still very limited to just compassionate care and, upon facility essential care. CMS guidance in September substantially expanded the ability of visitation to occur outside of compassionate care and essential care inside of facilities. And it was dependent, however, on county positivity rates. So what we've seen is when that guidance first came out, it was expanding visitation quite a bit. Now with rising COVID rates, it's not having quite that same effect. However, certainly encourage anyone who's wondering about the specifics there to check out the CMS guidance from September that was largely replicated at the state level, expanding the ability of visitation to occur, at least when COVID county rates are more reasonable. We're continuing to see concern about staffing, discharge eviction, dignity and respect. These have been common themes pre and post pandemic. I'm not going to spend a lot of time right now on essential caregiver visitation. I sort of passed over that, but that is another very significant part of the visitation puzzle that we have been working with. Next slide, please. Isolation is also deeper than visitation. So visitation is absolutely critical, but we also know that something that decreases isolation for people, especially those who may not have a lot of family support, for example, is being able to interact with the broader community as well as with other residents inside the facility. We've received complaints about residents who were prohibited from accessing the community other than for essential medical visits. We know there are some rules right now related to quarantine if someone were to leave. Over the course of the pandemic, we also received various complaints about people being asked to stay in their rooms, having no or limited access to the dining room, community activities. We know that more recent guidance has loosened up a bit the ability for some of those activities and things to occur. That is something that we've seen throughout the pandemic, group activities, social activities being canceled. Next slide, please. So what can families or others do to protect their loved ones during COVID? Remember, the Ombudsman always works from the perspective of the resident, advocating for the resident's request. So we're someone to contact our office. One thing we do want to emphasize is that we are always resident directed if the resident is able to give us that direction. We're is to use creative ways to communicate with residents using FaceTime, window visits, phone calls. Electronic monitoring law is something that was recently passed and also is a way with resident consent to allow for two-way communication, as well as for monitoring different things that may be going on in the facility. Families who do visit should follow infection control protocols, including wearing a mask and physically distancing from residents unless they are performing cares. And of course, please do not visit if you are sick. We encourage discussing the vaccine with residents and getting your vaccine when it's available, and talking to facility staff or your regional ombudsman for help if you have care concerns, rights concerns, other concerns related to the resident. And with that, I think that if you could go to the next slide, I think now I pass it on to Cheryl. Thank you.
Thank you, Genevieve and Aisha. I want to sort of think about all the great information my staff did share with you. And I pause to recognize there's so much more to share in terms of what we do, who we are, why we do what we do. And so if there are future opportunities for us to come together and provide more information, I offer that to Elder Voice. And I also want to state that there is guidance and policy and work being done out there that is extremely important in terms of raising the focus of resident rights. I also ask Elder Voice to join me in raising the voice of residents, because it's no secret how the voice can be dim, if not absent. And I have a sense that many families and loved ones who will be watching and learning from this particular session, you could be thinking, all of that is well and good, but that's not the way reality is for our family. We've been fighting and fighting to get in for a compassion care visit, and all of our words are just met with nothing. And so I recognize that, because what we share with you that's in guidance, policy, and law may be a lot different in reality. And that's why we're here with you. And I want to share one thing before we turn it over to questions and Chris and others. I value this relationship so much, but there are lessons that we are learning from COVID. There are lessons learned. We are all living history right now. And one of the lessons that I wish to share with you that I'm seeing from COVID among many is it's about the culture of the facility. It's about the culture of the long-term care setting. Facilities we are seeing that have a history of cooperation, they do their due diligence in staff training, and they focus on the residents, on the people that they are there to serve. Even when coping with staffing and regulatory limits, they are the places that have managed this crisis rather effectively. There are some out there. I also say another lesson learned, or something that seems to be coming up, and we have to face it, is the effects of ageism. And down the road, having a more of a conversation about this, a conversation of transparency. And so there will be, there are other lessons that we are learning throughout this pandemic, but I wanted to focus on the differences that we are seeing out there in terms of the cultures within facilities and how well that they promote a person-centered focus of care. With that, I will turn this over to the leaders of Elder Voice.
Thank you very much, Cheryl. And outstanding presentation, all three of you. We very much
Yes, thank
appreciate
you.
this. And I would ask Kate to remove the PowerPoint presentation from the screen, and I will then open it up. But first of all, Cheryl, I want to tell you, absolutely count on Elder Voice to be there, to work with you, to raise our voices together. We all know the Ombudsman and the people, the members, supporters of Elder Voice family advocates see the devastating impact that this pandemic has had. And we so much appreciate being able to work with you in a spirit of really making things much better. I also thank you, Cheryl, for pointing out there are good providers out there, and thank God for them. We very much appreciate them. There's also providers that are struggling, and we need to find solutions. And again, we'll work on that as well. And thirdly, thank you for bringing up that elephant in the room, and that is this issue of ageism. I believe it's a societal problem that we're all going to have to really tackle. And I think it's driving a lot of the issues that we're seeing in long-term care and more broadly socially. With that, I know that Jean and Nancy are probably anxious to ask a couple of questions, so I'll open it up to those two. Whomever wants to start.
I'll go first because I just have, thank you all so much. I know it's been really frustrating for you as an organization not to be able to get your eyes on our residents, and we know that, and we're glad that you're back in and helping. But one of the questions that I have is that we have had so many calls from family members and from residents from independent living who are being forced into the protocols of like a nursing home. And this is not, as far as infection control, no visitors, being told that they have to stay in their rooms when they just leased a senior living apartment, perhaps on a age-in-place campus. And do you have any advice for those individuals? Because that has been that's been a big part of the phone calls we've gotten.
Thank you, Jean. And I'm going to ask Aisha and Genevieve to jump in, but you raised a very important point. We too are hearing from many individuals living in independent apartment buildings that are part of a continuing care campus. And they are so concerned about how their rights are possibly being stomped upon. For why? They're renting an apartment. But I will also say that I'm aware of people, which now we see a light, correct? We're hearing vaccine, some vaccine has been delivered. the point I bring up about vaccine are people are wondering if I am part of a continuing care campus and I'm living in an independent apartment, am I part of the provider or the priority group of people who will be vaccinated? So I'm glad that you're bringing this up. And Aisha, Genevieve, do you have either of you have some quick comment to share of what you're hearing from our staff?
Sure, this is Genevieve. We are getting many calls about this. What's a little sticky for us is that technically our authority does not extend to independent living facilities where people are not receiving licensed services. So it's a little hard for our staff to be advocating and pushing hard for resident rights when it really is an apartment building, perhaps on a campus with other settings. So, we have had staff talk through it with people that they have rights. They should not be restricted. But there's not really an easy answer for this. I know some people have turned to legal providers for assistance to clarify their rules and their rights, and that may be what has to happen here.
What about the vaccine? I mean, because they're just in an apartment, are they going to be part of from what you're hearing, part of the CDC just came out with it, that they won't be part of the first initial phase, but because they're in independent apartments and maybe over 75, will they be later?
That is such a great question, Jean, and we are receiving that question. And I will respectfully say that it's a rather complex question to answer, because I have received information from some providers that they were asked to submit how many people within their communities would need to be vaccinated or fall within that priority level. And there may be some providers that they just put the number they gave included possibly the people who are living in independent apartments as part of their campus. So they were asked to give a number. And but is that happens to be a metro place, by the way. But is that what's happening up in northeastern Minnesota or the far corner of Southwest? I will say I was recently invited to be part of a vaccine advisory committee, and it was just so recent, Jean, that I'm trying to figure out what they have been doing to date, because I believe they may have been there before. So I think we need to continue to listen to what people are saying. And it would be difficult for me that if somebody living in an independent apartment wanted a vaccine and they were vaccinating people on that campus, it would be difficult to point to one over the other. I just have to be very honest about that. So I am at this point working with other people within leadership of government and other groups within actually people of local communities, local government, to make a point of how this is done, make sure that it's done right and accurate. Yeah. I don't know, Aisha, did you want to add anything to that?
No, we've been asking some similar questions, or Cheryl has, related to vaccine distribution. So it's certainly a question we're continuing to ask and try to get some clarity on.
Well, thank you. Our voices are so much better when they're together. They become louder, don't they? So we'll stay in contact on this one and see what we can do for the people living in independent living and have their questions answered. So thank you so much. We look forward to continuing our work together. I'll turn it over to Nancy. That was my blaring question that came up during the presentation. You answered all the other ones, so. Thanks.
Thanks very much. My question really revolves around people making their homes in assisted living and memory care who really cannot speak for themselves. And I still have a number of friends whose loved ones are in those communities. And when we talk about involving the Office of the Ombudsman for support, what I hear from them is this real fear of retaliation. Not overt retaliation like we are going to discharge your loved one, but much more subtle kinds of things where somehow the caregivers find out that a complaint has been made and they are just a little bit late with scheduled cares or later with scheduled cares, or don't respond as quickly when someone pushes a button for help. And family members are very, very concerned about this. So my question is about your role with the communities in terms of how do you help them understand that they can't retaliate or shouldn't retaliate? And I know it's different in different communities because some places would just say, oh, thank you for telling us. We'll get on this, we'll work with the family. That's wonderful. And along with that, what do you do when you note a concerning condition or the possibility of abuse or neglect? How do you share that with families and with directors? So I'm interested in kind of how you do the nuts and bolts of what you do.
I will ask Aisha and Genevieve to jump in, but I want to say thank you, Nancy, for raising the whole issue of retaliation. I will tell you and your members that I'm the state ombudsman, and I have had family members that have needed long-term care or hospital care. And they at times have begged me, please don't tell them what you do for a living, because if you do, then I'm going to get skipped next time. And that just breaks my heart because no one should ever be in a position to say, I'm really afraid that if I say something about that, a problem, and I'm talking about even if it's so much as I lost my sweater, all the way up to my my request for assistance to use the restroom, or even more critical needs are going unanswered. That is important. And so it is a topic that is extremely important. And I started in the office as a regional ombudsman, and I used every opportunity I could to educate staff and provide in-service training on resident rights that prohibit retaliation. But you bring up a very important point, that not all of it is clear cut, dry, that's retaliation. It happens covertly or in a subtle way. So I want to turn it over. Aisha and Genevieve may have just a brief to talk about what can be done. But I will say, people, please reach out and talk to us about it confidentially so that we know what is going on, and we will work with you to come up with a plan about how we're going to approach it. And yet, to your point, Nancy, again, thank you for bringing this up as it relates to serving people who are in the advanced stage of memory loss.
Thank you, Cheryl. Those are such great points. And I think what Cheryl said is so critical, that the first step could be contacting our office. And we really encourage people to do that, and understanding that contacting the office does not mean we're going to jump to something that the family member or the resident is not comfortable with. It's really about first contacting the office, knowing that we are a confidential service and whatever you tell us is confidential. And under the federal regulation, part of it is creating a plan of action with the resident, or if the resident cannot speak for themselves, with the substitute decision maker, or if there's not a substitute decision maker, to be working with family members, others. And this office can act even if there is not a substitute decision maker formally in place, based on investigation, based on determining what needs to be done in the best interests of the resident. So there's really no situation that we can't be called on to see, how are we going to move forward with that investigation? What is that going to look like? To what extent are we able to involve the resident or not, depending on their particular level of capacity? Are they verbal? Can we speak with them? So certainly we attempt to involve them as much as possible in every case. Now, in terms of the tools that are available, one of the tools that we always attempt to use when possible is self-empowerment. And so sometimes there may be a resident who doesn't want the Ombudsman's office as a first step to be the one to speak out about a particular issue. It may be educating the resident or the family member on what the resident's rights are. And then maybe what they're most comfortable with is first speaking themselves, feeling more empowered that they know what their rights are, and speaking out themselves. If that doesn't work well, or that's been tried in the past, then we can speak to the facility management if that's something that the resident is comfortable with. And many times the regional ombudsman will already have a pretty well-established relationship with the facility staff. We work hard to build those, to build a certain level of trust. If we can't get the things involved ourselves, there's always the possibility of other tools, like involving the Department of Health. And one of the things that we did work on as part of the broader assisted living package, which wasn't just about assisted living licensure, it included other things, but was increased protections related to retaliation. And those laws were put into effect for situations that cannot be resolved easily, to create that ability to file a complaint, to take formal action. There's other referral sources that we can use as well. Another tool that we talk about is electronic monitoring. And that may not be a tool that works well in every case, and where there's resident consent that's capable of being received. That's an important piece of the puzzle. But sometimes electronic monitoring can provide some reassurance to residents and family members that they are going to be receiving care in a timely manner or be treated respectfully. So that's another tool that, again, was part of that broader assisted living package that is out there to help address retaliation. A final piece I would add is, as I mentioned earlier, we have the ability to do systemic casework. So let's say there is a resident or family member that's calling about long wait times, but they do not want to contact the facility directly for whatever reason. If we have a sense that this is not just an issue for this particular resident, but maybe an issue facility-wide, we also have the ability to talk to facility management in certain cases about those issues on more of a systemic level, as opposed to bringing up the resident name. I hope that's helpful.
Yeah, yes, that is very helpful. And a follow-up question is, when you are helping family members or friends who might be helping family members, are you providing guidance and support for if they've been denied compassionate care visits, or if they have been denied essential family caregivers, and helping them phrase what to ask for, so that the community will listen to them and will respond in a way that isn't simply, but we had another COVID case, which is what people are hearing in some places. And so what can the ombudsman do to kind of help people speak for themselves in those areas?
This is Genevieve. I can tackle this one. The regional staff spend a lot of time troubleshooting these kinds of calls. Again, this is a big focus. A lot of family and residents are calling upset that they can't have visitors, and so it's a whole range of troubleshooting. We recently had a case where the facility had an outdated policy. And so the staff thought that they were following the right policy. As we know, there's been a lot of changes throughout COVID. And so the regional ombudsman asked for the policy. That's something we often do. Realized it doesn't line up with current MDH guidance, pointed that out to the facility staff, and they allowed that person to have an essential visitor, and many other residents in that building also were then allowed to have essential visitors because they were able to realize that was wrong. So there's a whole range of tools that we have, and that is definitely making the connections for residents with family and friends is definitely a priority as we see how difficult social isolation is for mental and physical health for residents.
Thank you very much. That is really helpful, that people don't necessarily need to be identified to the community as having a concern. It can be done in a broader way.
Well, I think that concludes our session today, and I thank Cheryl, Aisha, Genevieve, outstanding presentation, and we so appreciate your work, and we look forward to working with you in the coming year and years to come. So with that, I would say goodbye. Thank you very much.
Thank you.
Thank you all.
Bye. Thank you.